Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And today, I'm delighted to be joined by Chad Adams. He's the president and CEO of Medic.Life. Chad, thanks for joining me today.
Thanks for having me on your show.
So for the benefit of the listeners, I always like to get a little bit of background to the individuals. Could you share a little bit of your history and how you got to this role and position?
Yeah, so I'm a very purpose-driven individual. So I've spent about the last 25 years developing medical devices, diagnostic systems, cellular research tools, really to focus on some of healthcare's biggest challenges. And I tell my kids this. I remember a time in my career when HIV was considered a death sentence. And now if you look at it, it's basically a chronic disease. And from what I've seen in my career in cell therapy and in the genomic side, I believe cancer is going to be the same way, definitely within our lifetime.
Yeah, no, I would agree. I think I've had the same experience. It used to be absolutely a death sentence, and now we have it essentially as a controlled disease, and a pretty well-controlled disease with medications that have been developed along the way. It's a fascinating sort of innovation, and I think entirely relevant at the moment as we sort of think about other viruses. You know, there's obviously hope around that. Absolutely. Tell us a little bit about Medic.Life and, you know, the company. What is it? How did it come about, and what is it that you're doing?
Yeah, Medic.Life, the best way to think about it is really around the problem we're trying to solve. So the problem is right now is there's about 70% of our healthcare costs are preventable illnesses.
Right.
If you look at, most people don't even know they have a chronic disease or don't know they have it. And if it could be prevented and people knew early enough, we could put treatment options in place and really have a big impact on this. And I mean, a couple of examples, and three that I like to talk about is, the first is, over 88 million adults, almost 35% of our population have prediabetes.
Right.
And worse than that, 8 in 10 don't even know they have it. Hypertension, the same way. Number one contributing risk, for global death. 5 in 10 don't know they have it. I was one of those individuals myself. And if you've usually had one or both of those, then chronic kidney disease, you look at 37 million. This is Americans. It's 15% of the population have chronic kidney disease, and 9 out of 10 don't know they have it. And so what we're really doing as a business is we believe prevention through early detection is the best cure. And so to solve this problem, though, the solution has to be simple, convenient, and really fit naturally into a person's daily life flow. I mean, there is a cure for this right now. You just got to go to your primary care physician, or you have to go to your care providers. It just doesn't happen. And so what we're trying to do is prevent that elegant solution that fits into a person's life, that we can basically early detection and, provide the data insights for individuals to be able to get preventative care early.
So I 100% agree. I mean, and in the vast majority of these cases, that early disease is contributed to by what we do with our lives and the way that we behave from a nutritional standpoint, exercise, and, some of the additional loading, with smoking as an example, that, contributes in a negative way. And our opportunity to bend the curve in terms of both cost and outcomes is, always tilted towards the front end of this. So well established, a clear opportunity. What is it that Medic.Life does?
So Medic.Life basically does a urinalysis on you every time you go through your daily routines, every time you go to the bathroom. It requires you to do nothing. So every time you go in, key analytes are looked at, biometrics, circulation in feet, everything that contributes to some of these big problems, these big chronic diseases, it's actually monitoring all along. And then through some of our AI and some of our analytics engines, we're actually able to look at it over time. So it's this longitudinal tracking to see these things moving one way or the other towards good or bad, and be able to give that information back in a very simple way to the users, and for their healthcare providers, the more detailed information like you'd see in a core lab result for your analysis.
So what we're talking about is a lavatory, a toilet, multiple terms for this, but it's essentially something that hopefully everybody has in their households.
Absolutely.
It's widely used, and what you've essentially done is engineered this in a way that allows you to apply routine analysis every time somebody uses that toilet. So help me understand, because that doesn't sound like a trivial thing to do. In the design of these devices mixes everything with water, so that's already a problem. Help me understand how you got to this point, because obviously it sounds very elegant, but equally very challenging.
Yeah, so it is a technology-driven toilet, that's for sure. And one of the keys to how we solve this problem is actually capturing the sample before it's diluted into the water. And so that's fundamentally part of the design, is to be able to do a very complex sample prep system, but very easy in the context of the user.
Now, is there anything that user has to do as part of this, or is it literally, here it is, I'm going to go to the toilet and I don't sort of think about it? Is it an entirely passive process?
It is. And that's a good word you use there. Is it's very passive. So the only thing the user has to do is authentication, and this is done very, very easily with Bluetooth technology. And because of personal health information rights with privacy, there's always a two-factor component that goes on as it authenticates the user as it approaches the toilet, but they don't have to do anything. That two-factor is actually done within the software just to be able to make it from a HIPAA compliance and from a privacy standpoint.
So even the authentication is passive by the sounds of it. Once you've set it up, so there's obviously a sort of registration process, but then it's tied to the devices that people have, and it's based on that proximity that says this is the individual, and therefore that allows you to authenticate.
It is. So it depends on the set. That's for the consumer, or for the retail clinics or others that would use this, because of the people that are part of the programs, the wellness programs and what that are part of that. They all have a cell phone. They always have an Android or a smartphone, iOS. And so very, very simple to set up and authenticate that way. There are certain care settings, if you think about especially chronic diseases, the elderly and assisted living centers and some of those areas where it's not so prevalent. So there's other options such as RFID and other ways to still keep it passive, but also authenticate, back to the user.
Passive acquisition, passive authentication, and that answered one of the questions that I had was, how do you know who's the right person? This is obviously part of the sort of built-in technology. Tell me a little bit about the sampling process, because that doesn't sound an easy thing to do. How did you go about that? What was the sort of process? Were there any learning points through that in terms of the sort of design and thinking of that?
Yeah, absolutely. I mean, if you think about diagnostics in general, whether it's immunoassays or just clinical diagnostics, the most common samples are blood, urine, of course, tissue, and so tremendous number of biomarkers are prevalent in all three of those, of course. And so the focus was around using the urine to be able to, in an undiluted format, to be able to do non-contact analysis. So we use spectrometers, so near infrared, different wavelengths, to be able to interrogate the sample, and then of course put it back together with our AI in the background. And we're not just looking at one thing; we're looking at many analytes, many different contributing factors, and building risk models associated with that only get smarter and stronger over time the more you use the toilet.
Right. But I'm actually thinking sort of a step before that actual process, as you pointed out, before the mixing with the water that's already there. How do you go about that? Is there some sort of sensor that pokes out through the whole process? What's going on in that?
No, so we have it's a slit that actually sits in the rim of the top of the toilet bowl. So as you urinate, the urine actually circles around by design to where it actually channels it into this little slit. And that's where the samples actually, all the interrogation is done, is right there before it ever gets to the bowl. Then as you flush the toilet, it cleans it out. It's just all part of the fluidics, system that's put in place on the toilet.
So I have to believe when you came up with that wasn't your first model? I mean, I'm just curious about the sort of design process that got you to this point.
Yeah, I have to give the credit to David Hall, who was really the initial person that started focusing on this problem. And I don't know if you know David in Hall Labs. He really created an Edison Research Center here in Utah, and his focus is on solving the really, really big problems, and not marginal ones, but when he looked at chronic disease and managing and prevention, he's like, what would be the easiest way to do this? And so he worked on many different design configurations over probably 8-9 years before it actually started to come to fruition. Things, as I've seen pictures, it was before my time, a big microscope sitting up up on toilet bowls and lots of other different configurations. But it was really started to come kind of hardened from a technology standpoint about 1.5 years, 2 years ago, when they got to the non-contacts, when they found spectrometers that were small enough that could actually fit in this form factor and cost effectively fit into this form factors.
Fantastic. So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Chad Adams. He's the president and CEO of Medic.Life, the producer of the smart toilet, or Medic.Live, I think. We were just talking about the whole sample collection, which, in its own right is a very challenging thing. But now you've got the sample, you've managed to grab it, you're interrogating it. Tell us a little bit about what's going on behind the scenes. So you talked a little bit about spectroscopy. What else are you doing to be able to analyze the sample?
Yeah, so we use many, many different sensors depending on the chronic disease that we're focused on. And probably the base chronic disease, we're using non-contact. So we're using the spectrometers. We're also using the fluidic system itself. So if you think about BPH, enlarged prostate challenges there, you're able to very simply, just by measuring the volume, the start stops, the overall volume, the time, the duration.
So even that, right?
All of these different things, which are very easy. They're all calculated based on the volume of the system. And so many different sensors that you look at and different approaches actually to focus on it. So we also use things, for heart rate variability. We can look at blood pressure, blood oxygen. So these are things as you approach the toilet, you stand on a scale, so it takes your weight. As you sit down on the seat, it actually has all your biometrics. So it's checking blood pressure, body temperature, looking pulse wave, velocity, looking at irregularities in heartbeat and rate. We're using load cells, to actually do a lot of different calculations on these different areas. And so everything we've been talking about so far has been preventative. We also have what we call the Science Center, to where we can do label-free real-time PCR. So we can do molecular testing. So we figure if you actually get the sample, that's the hard part, is getting the sample. Once you get it, it's easy to direct it to the type of detector that you want. And so we use NanoFet as the technology. So we functionalize the chip with antibodies, oligos, you name it. The molecule capture is actually embedded right on the chip. It's the disposable that would go. This is the only. Everything else, there was no disposable. It was completely passive. So these more advanced. So if you think about coronavirus, single cell, SARS or any, and that, or even infectious disease pathogens, we can do real-time PCR, label-free, with very little reagent, very inexpensively, and actually screen for infectious disease. We can also, some of the examples we were talking about earlier, if you weren't able to prevent one of the chronic diseases, and you need to monitor, for example, chronic kidney disease, you can actually do it right in your own lab. So you can do a full equivalent accuracy as a full scale lab for chronic kidney disease, cardiovascular disease, like I say, some of the pathogens that are very prevalent right now.
So one of the things that you talked about there was the sort of different sensors depending on the disease. So you've actually got a sort of a customized portfolio of toilets that people can select depending on their challenges, or do you have a Cadillac version that says, hey, we're going to cover the whole lot? Is that a possibility? How's that working?
Yeah, so what we're calling the Medic.Lab right now is really focused on prevention, and it's 6 of the kind of most common. So, for example, we're looking at obesity, hypertension, dehydration is one that we can measure specific gravity of urine very easily and very accurately. Diabetes, specifically prediabetes, risk, CVD or cardiovascular disease, BPH is another area that we focus on. These are kind of the basic ones that we can do very easily, and no different than every time passively that you use your facilities. That's the first version. And so to give you an example of, if you think about diabetes risk, it's not just one factor. So we look at elevated glucose, the ketone. We're looking to see if how much ketone, if it is in the urine, it shouldn't be there. It's a good indicator. Elevated obesity risk, which has many factors that is being calculated into that or being measured. Elevated hypertension, of course, we're taking blood pressure and many other, body, BMI and other factors that go back into the algorithms that actually are quite accurate in predicting, for example, prediabetes in this case. We'll even look at things like, sudden weight loss, increased urination frequency, poor blood circulation in the lower legs. We use, CMOS sensors to actually, we can look at, pre-diabetic factors from circulation, especially in the lower legs. So it's many things. So It's not that we're just looking at one individual thing. We're looking at many factors and using our algorithms to really build the comprehensive risk panels.
And one of the things that jumps out at me that I hadn't thought about, but we all talk about, is it the 6, or I don't even remember how many glasses of water we're told to drink, and nobody's really sure about the validity of that. But here we have an opportunity to actually measure dehydration or measure whether somebody does have dehydration and apply it. I think in most instances, many people don't drink enough, and an opportunity just on a simple level, then, all of that layered on, which I think is, again, it's more data is going to give us more insights. We don't have a lot of time left, so I want to drill into a little bit into that sort of expanded opportunity. And of course, contextually right now, everybody's talking about COVID-19. You'd need the test for COVID-19, which I don't think we have. We do know that there's fecal presence for the virus, so there's potentially that route, but I don't know if it's in urine. But obviously, if the test is available, you can essentially modularize that. So you have a modularized capability to insert any of these tests that are based on access to urine or feces. Is that a fair assumption?
It is. So this technology, which is the next phase, which is about a year and a half behind the Medic.Lab, that uses the real-time PCR component. You can get in urine, actually, even with COVID-19, you can get the equivalent concentration or the equivalent as you do out of the nose and a nose swab.
Wow.
So there's actually quite prevalent, so you don't even have to go to fecal. You can do it, which we have the capability of doing as well in the Science Center component. But it is available. It's could be easily done. We've done it with the last SARS. That was actually proof of principle was on that single virus.
Wow.
So we're actually working on that panel right now.
So you've actually got the setup to be able to, it all, as a sensing sensor, it almost, hey, go in and use the restroom, and now suddenly you've got an alert, which, one of the things that people are complaining about is we just don't know. And here we've got an opportunity as a passive activity. And I know there's all sorts of scary outcomes and potential misuses, but ultimately more data is valuable in this. Here's an opportunity to provide more data and insight for individuals every time they use the restroom.
Yeah, I mean, this is definitely an isolated event, at least in my lifetime. But you think about just the social distancing and the ability to be able to do your own testing in your own house, or even if you, as now with the CVSs and the drive-throughs and even the hospitals, you could very easily have this as a screening tool,
right,
for people with really no contact.
Well, that's exactly right. It's a no contact issue. One of the challenges with our current method of screening. I think South Korea is the exception that I've seen, where they've got the telephone booths and full glass and protection between the tester and the individual. In most instances, the people doing the testing are at much higher risk as a result of being in close proximity to people that are potentially shedding the virus. So here's an option to say, I can keep you completely separate. You've got a cleansing mechanism built in. So this is extraordinarily exciting to be able to see the potential, and fascinating to hear that you used SARS, or SARS was your proof of concept. We've got a couple of minutes left. If I could ask you to just sort of think about where you see this going. Obviously, you've got the foundational model, you've got this extension capability. What are your options? You've got all of this AI, this data. How do you see this developing?
Yeah, so there's different needs in different markets, all focused around the same chronic disease, either prevention or chronic disease management. The simplest one would be the healthy consumer. So the ones where you have these in your home, if you're concerned about your own health, your own families, it's you basically have a clinical lab in your lab, if you will. Not no pun intended there, but
no, absolutely.
You also, if you think about our elderly population and you look at the growth, both not only in the U.S., but you look at around the world, just at the doubling basically in the aging population over the next 30 years, the ability to be able to keep them healthy, keep them mobile, it's going to be a big challenge, and wellness is going to be a big component of that. And so you can imagine these being in the assisted living or even independent living facilities as part of wellness programs. You think about the move to more convenient healthcare access, to like the Minute clinics or the health hubs or the retail clinics, and the working with the payers as well as the telemedicine providers to be able to have wellness programs to keep everybody's premiums lower, actually, and get our healthcare cost. Like we see a very big opportunity there to make a big impact on people's health and on this problem of chronic disease, and also very convenient in a lot of different settings where it's not a very convenient method right now.
Fantastic. I mean, I think, tremendously exciting as we see this clear sort of shift, albeit forced, but I have this sense that we're not going to be stepping back from this move to the medical home, the treatment in the home setting and in smaller settings versus hospitals. Here's technology that can not only be placed in all of those clinics and these other areas, but also in the home setting, and provides essentially a potential to screen and provide all of this data in both to the individual, which you've obviously got as part of this, but also into the clinical systems from a value proposition. I think tremendously exciting time, and also, quite frankly, very timely given what's going on. So very excited about this. Really appreciate you making the time to come on the show. Look forward to seeing how things develop going forward. But just remains for me to thank you, Chad, for joining me on the show.
Thank you for having me.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.